If I told you that your blood pressure of 118 over 95 could be more dangerous than one of 145 over 80, would most of my patients believe me? No, and I understand why. For years, all of us, doctors included, have trained people to look at only one number, the top one, the systolic. That big number that appears first on the blood pressure monitor and that everyone memorizes as if it were their postal code. But here's the problem. While you obsessively watch that upper number, the lower number, the diastolic pressure, could be telling you a completely different story about what's happening inside your arteries. And in people over 60, that story is sometimes more urgent than the one from the top number. I'm a family doctor, and over the past 10 years, I've seen hundreds of patients with normal blood pressure according to the top number who were actually at real risk. I've also seen the opposite, patients obsessed with lowering their systolic who, without knowing it, pushed their diastolic into a dangerous zone. In the next few minutes, I'm going to explain exactly what that lower number means, why it can go up or down independently of the upper one, what the J-curve phenomenon is that probably no one has ever explained to you, what arterial stiffness is and how it's measured indirectly, and how to read your own blood pressure the way a doctor would, not as an isolated number. And before this video ends, I want you to know exactly what to do if your reading is 120 over 95, 140 over 90, 110 over 60, or any other combination. And I'm even going to debunk some myths you've probably heard about blood pressure that are completely wrong. Stay with me, because this could change the way you understand your own cardiovascular health forever. Let me tell you about a patient I'll call Joseph. That's not his real name, but his story is real, and I've seen it repeat itself dozens of times. Joseph was 67 years old, he exercised, watched his diet, and every time he came to the office, he would proudly say, "Doctor, my pressure is perfect, 128 on top," and I would look at the bottom number, 96, consistently above 90. Joseph, like many, had been trained by the internet, by friends, even by some hurried healthcare professionals, to ignore that second number. But that second number was, over time, silently stiffening his coronary arteries. I'm not telling you this to scare you. I'm telling you because I want you to understand something that many doctors don't have time to explain in a 10-minute appointment. Blood pressure is not a number. It's a window into the actual physical state of your blood vessels. And that window has two panes, the systolic and the diastolic. Ignoring one is like reading only half of a sentence and thinking you understood the complete message. Let's get into the physiology, but in a simple way. When someone takes your blood pressure, the device measures two distinct moments of the cardiac cycle. The top number, the systolic, measures the pressure at the exact moment when your heart contracts and pushes the blood out into the arteries. It's the moment of maximum force, the push. But the heart isn't always contracting. In fact, it spends more time relaxed than contracted, approximately twice as much time in each cycle. That moment of relaxation, when the heart fills with blood for the next beat, is what the bottom number, the diastolic, measures. Think of your circulatory system as a garden hose connected to a faucet with an intermittent pattern. The systolic is the pressure right when you open the faucet to its maximum. The diastolic is the pressure that remains in the hose when the faucet is closed between spurts. If that residual pressure, the one that remains when the faucet is closed, is too high, it means that the hose, that is your arteries, isn't relaxing enough between beats. And why does this matter? Because healthy arteries aren't rigid tubes like a plastic hose. They are living elastic structures that expand and contract with each beat like an accordion. That elasticity has a technical name, arterial compliance. When your arteries are young and flexible, they absorb the impact of each beat and cushion the pressure, allowing the diastolic to drop adequately between contractions. But here's the twist I want you to understand deeply. With age, the collagen and elastin of the arterial walls begin to lose flexibility. It's a process called arteriosclerosis, not to be confused with atherosclerosis, which is the buildup of plaque. Arteriosclerosis is literally the progressive hardening of the arterial wall, similar to how a new rubber band stretches easily, but an old dry rubber band becomes stiff and brittle. There's even a way to measure this stiffness more precisely than just with the blood pressure numbers. It's called pulse wave velocity. Without going into too much technical detail, it basically measures how fast the pressure wave travels from the heart to other parts of the body. The stiffer the artery, the faster that wave travels, similar to how sound travels faster through a hard material like metal than through a soft one like rubber. It's not a test that's done routinely in every appointment, but if your doctor suspects significant arterial stiffness, they can request it at specialized centers. When arterial stiffness advances, something curious happens with your two numbers. The systolic tends to rise because rigid arteries don't absorb the impact of each beat well, but the diastolic tends to drop because those same rigid arteries don't retain residual pressure like they used to. This explains why many people over 65 to 70 years old have high systolic and low diastolic simultaneously, a pattern called isolated systolic hypertension, which we'll talk about in more detail later. But before we get there, I need to explain what happens when the diastolic is high, because this is Joseph's scenario, and probably that of many of you watching this video, with a reading like 130/92 or 140/95. Here comes something that very few patients know and that took me years of clinical practice to fully understand. The heart muscle, the myocardium, does not receive its own blood supply during systole. That is, when the heart contracts forcefully to pump blood to the rest of the body. The coronary arteries, the ones that feed the heart itself, are partially compressed by that same muscular contraction. Sounds contradictory, doesn't it? The heart works, but doesn't feed itself while it works. So when does the heart receive its own oxygen? During diastole, during that moment of relaxation that is precisely what the bottom number measures. Now imagine this, if the diastolic pressure is chronically too high, the coronary arteries have to work constantly against an elevated resistance, even during their moment of rest. It's like asking someone to breathe deeply to recover after running, but while someone is squeezing their chest all the time. True rest never comes. There's never a complete recovery. With Joseph, this is exactly what was happening. His sustained elevated diastolic, year after year, was generating what we call left ventricular hypertrophy. The heart muscle, working constantly against that elevated resistance, begins to thicken like any muscle that exercises under excessive load. But unlike a bicep that strengthens with exercise, a heart that thickens this way becomes less efficient, more rigid, and at greater risk of arrhythmias and heart failure in the long term. We did an echocardiogram on Joseph. It confirmed what I suspected, thickened ventricular walls. That finding in a man who felt perfectly healthy was a wake-up call that completely changed his treatment approach. Before I continue, I want to speak to you as a doctor, not as a salesman. Many of the questions you ask me daily, I've already answered in 3 guides: the complete guide to the heart and blood pressure to care for your circulation from home, 101 natural remedies for everyday use, and the definitive longevity plan so that all that care translates into more years of life with health. Today, and only for 24 hours, each one costs €9.99 instead of €39.99, and all 3 together only $24.99. You have the link below the video. Take a look whenever you want. Start caring for your health today. Now I want to tell you about another patient because his case illustrates a very common mistake I see constantly. I'll call him Anthony. He was 62 years old and came to my office convinced that he had severe hypertension because at home he had measured himself several times at 150/95. But when I took his blood pressure myself in the office using the correct protocol, I got 128/82. What had happened? Anthony had what we call reverse white coat hypertension, although his case was actually different. He was measuring his blood pressure immediately after stressful discussions with his son over video call, without resting first, with his arm poorly positioned, and using a low-quality wrist monitor. His anxiety about the measurement, combined with technical errors, was generating falsely elevated numbers that had him living with unnecessary fear. This case is important because it leads us to a topic I want to address directly: the myths about blood pressure that constantly circulate and generate confusion. Myth number 1, if I feel fine, my blood pressure is fine. This is false. Hypertension is called the silent killer precisely because most people with elevated blood pressure feel absolutely nothing until significant damage has already occurred in the heart, kidneys, or brain. Myth number 2, diastolic pressure stops mattering after a certain age. Also false, although partially understandable, given that it does indeed change its behavior with age, as I already explained. But an extremely low or extremely high diastolic is still relevant at any age. The context of interpretation simply changes. Myth number 3, if I take my medication, I no longer need to measure my blood pressure regularly. This is dangerous. Medication reduces risk, but doesn't eliminate the need for monitoring because the necessary doses can change over time, with weight, with other medical conditions, and even with the seasons. Yes, many people need medication adjustments between winter and summer due to changes in blood vessel dilation caused by temperature. Here is where the story gets more interesting, and where I want you to pay special attention if you are over 65. For a long time, medicine operated under the principle, the lower the pressure, the better. And up to a certain point that's true. But in the last 15 years, cardiovascular research has revealed something we call the J-curve phenomenon. Imagine a graph. On the horizontal axis, you have the diastolic pressure from very low to very high. On the vertical axis, you have cardiovascular risk. Simple logic would say that line should be straight. More pressure, more risk, always. But reality is not a straight line. It's a curve shaped like a J. What does this mean? That yes, when the diastolic rises too high, the risk increases. We already explained that with Joseph. But when the diastolic falls too low, below approximately 60 millimeters of mercury, the risk also begins to rise again, forming that characteristic J-shaped curve. Why does this happen? Remember what I explained. The heart feeds itself during diastole. If diastolic pressure drops too much, the coronary perfusion pressure, that is, the force with which blood effectively enters the coronary arteries, also drops. The heart paradoxically starts to suffer from lack of oxygen, not from excess pressure, but from insufficient pressure. This is especially relevant in older people who already have some degree of narrowing in their coronary arteries from cholesterol plaques. If those arteries are already partially obstructed, and on top of that, the perfusion pressure drops too much due to an excessively reduced diastolic, what we call silent ischemia can occur. The cardiac muscle receives less oxygen than it needs without the person feeling obvious chest pain, especially if they also have diabetic neuropathy, which dulls pain perception. I had a patient I'll call Catherine, 74 years old, with lifelong hypertension, aggressively treated for decades. When we finally managed to lower her systolic to 118, her diastolic had dropped to 58. She felt dizzy when getting up, with episodes of unexplained fatigue. These weren't random side effects. They were signs that we were pushing her pressure toward the wrong side of the J-curve. We adjusted her medication, not to raise her blood pressure in an uncontrolled way, but to find that point of balance where her systolic was controlled without sacrificing an adequate diastolic. Her energy came back within a matter of weeks. This is a crucial point I want to emphasize. The goal of blood pressure treatment should never be simply the lowest possible number. It should be to find the optimal range for each individual person, considering their age, their cardiovascular history, and how they feel functionally in their daily life. Let's go back to something I mentioned earlier because it's crucial for most people watching this video. After 60 to 65 years of age, the most frequent pattern I see in the office is not a high diastolic like Joseph's. It's the opposite. High systolic with normal or even low diastolic. For example, 155 over 75 or 148 over 68. This is called isolated systolic hypertension, and it occurs precisely because of that progressive arterial hardening I mentioned at the beginning. It's important to understand that this is not less dangerous, simply because the diastolic is in the normal or low range. In fact, isolated systolic hypertension is strongly associated with a greater risk of stroke because the repeated impact of an elevated systolic pressure on already stiff arteries, especially in the brain, can progressively damage the small vessels, generating what we call in brain imaging leukoariosis, or white matter damage, associated with an increased risk of cognitive deterioration over time. But here's the important clinical nuance. In this specific pattern, the difference between systolic and diastolic, what we call pulse pressure, becomes a key indicator. A wide pulse pressure, for example, greater than 60 to 70 millimeters of mercury, is in itself a signal of significant arterial stiffness, regardless of what the exact number of each component is. So if your reading is something like 145 over 70, you shouldn't think, my diastolic is fine, no problem. You should think, my pulse pressure is 75. That indicates that my arteries have lost elasticity, and that deserves medical attention, even if the bottom number seems reassuring. Let's get practical. I promised you at the beginning of the video that you would know exactly what to do with your number. Let's go case by case. 120 over 95. This is Joseph's case. Seemingly perfect systolic, worryingly elevated diastolic. This is called isolated diastolic hypertension. It's less common, but no less serious, especially in middle-aged people with excess weight or insulin resistance. It requires medical evaluation, typically confirmation with 24-hour ambulatory monitoring before deciding on treatment, because a single reading can be influenced by stress, caffeine, or what we call white coat hypertension. 140 over 90, the classic threshold for hypertension according to traditional guidelines, although the most recent American guidelines lower the threshold to 130 over 80. Both numbers are elevated in a proportional way. It deserves follow-up, lifestyle changes, and possibly medication depending on your overall cardiovascular risk, not just this isolated number. 110 over 60. For many people, this is completely normal and healthy, especially if there are no symptoms. But if you are over 70, have a history of coronary disease, and also experience dizziness or fatigue, this reading deserves review because you could be in the low territory of the J-curve I explained earlier. And I want to add a fourth case that I didn't mention at the beginning, but that I see constantly, 160 over 65. This pattern with a very elevated systolic and a relatively low diastolic generates an enormous pulse pressure of 95 millimeters of mercury. This is probably the highest risk pattern in people over 70 because it combines the damage of the elevated systolic impact with the risk of inadequate coronary perfusion from the low diastolic. If your reading looks like this, don't wait for the next annual checkup. Talk to your doctor soon. The key, and I want you to take this away as the central message of the entire video, is that no isolated number, neither the top one nor the bottom one, tells you the complete story. What matters is the context, your age, your symptoms, your history, the consistency of the readings over time, and the relationship between both numbers. I want to spend a few minutes on something I constantly see done wrong and that completely distorts the numbers that then generate unnecessary anxiety or false reassurance, like what happened to Anthony. First, sit for at least 5 minutes before measuring, with your back supported, your feet flat on the floor without crossing your legs. Your arms should be supported at the level of the heart, not hanging or raised. A very common error is measuring while standing immediately after walking or climbing stairs, which artificially raises both numbers. Second, avoid caffeine, exercise, and tobacco at least 30 minutes before the measurement. These factors can temporarily raise both the systolic and diastolic artificially. Also avoid talking during the measurement, something that seems trivial but can alter the reading by several points. Third, take at least 2 readings separated by 1 minute, and if possible, measure in the morning and at night for several days, not just once. A single number at a single moment is like a photograph. What your doctor needs is the complete film. Fourth, use a clinically validated monitor for the arm, not the wrist, since the latter tend to be less accurate, especially in people with arrhythmias or significant arterial calcification. And finally, keep a record. A simple notebook or a spreadsheet with date, time, and both numbers gives your doctor infinitely more valuable information than a single reading taken with anxiety in the waiting room. I want to be clear and direct here because this video does not substitute for a medical consultation, and I need you to know when to act. Consult urgently if your reading exceeds 180 over 120, especially if it's accompanied by chest pain, difficulty breathing, intense headache, visual alterations, or confusion. This may indicate a hypertensive crisis that requires immediate attention. Consult on a scheduled basis, not urgent, but priority, if you consistently observe over several weeks a diastolic above 90, systolic above 140, pulse pressure greater than 70, or diastolic below 60, accompanied by dizziness, fatigue, or fainting. And consult simply for a routine checkup if your numbers are fluctuating, if you're taking new medication, or if you simply haven't checked your blood pressure in the last 6 months. Prevention in cardiology is almost always worth more than reaction. I want to end this video with the same thing I told Joseph after that echocardiogram. I said to him, it's not about being afraid of the numbers, it's about understanding them. For years, medicine simplified blood pressure to a single number because it was easier to communicate. But you, after these 30 minutes, know something that many patients don't know. That bottom number, the diastolic, is not a secondary detail. It's a window into how your heart recovers, how your arteries age, and how your body maintains the delicate balance between enough pressure and too much pressure. If you take away just one thing from this video, let it be this. The next time someone takes your blood pressure, look at both numbers. Ask your doctor what the relationship between them means, not just whether it's high or low. And if you are over 60, consider specifically asking for an evaluation of your pulse pressure and your risk of arterial stiffness, not just a standard reading. If this video has been useful to you, consider subscribing to the channel, where every week I go deeper into topics of cardiovascular health and prevention for adults over 60. I'll see you in the next video. This video is informational only and does not substitute for a medical consultation. The patients mentioned are anonymized cases. Always consult your doctor before making decisions about your health.